You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years of EMS experience. Each month we discuss EMS news, medical science, and review actual EMS calls, offering many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone to the Medic Materials Podcast. I am Mike Turek. We're here with Emily and Gerard and Kelsey, newly minted, card-dripping EMT.
Our now resident
EMT. Sorry, you're now the resident nurse, I guess.
Yeah.
I didn't hear that.
Okay.
Okay. I don't want to overshadow your excitement of being a new EMT, but I'm going to overshadow your excitement of being a new EMT today because we have the coolest guest ever. Cue music. Everyone, I want you to meet my lovely wife, Jess. She's a flight nurse as well as a volunteer EMT. And she's going to be joining us on this call review because it does pertain to some flight stuff. So that'll give her the opportunity to comment on it a little better than we would. We can just assume what they do. She can tell us this is exactly what they do. So hi.
Hi. Thanks for the introduction, hun.
Sorry, I have to.
Okay.
At least you remembered to introduce you this time.
I did.
Yeah.
Inside story.
The filter tried, it wouldn't stop.
It's quite all right. I feel like with that story, it's totally warranted. I will be beat down for that among many for the rest of my life. It's okay. And I still beat down on her the time that she punched me in the head while I was sleeping. So, I mean, each have their own, I guess. So,
Okay. Corey gave me a black eye doing that. But he's the one that tells everyone, like, anytime he gets a surgery, he's like, my wife beats me.
Yeah, that sounds like Corey. So we're going to dive into today's call review, and typically this is our discussion episode, but as I stated in the last one, I wanted to throw this call review in because it kind of touches on a lot of the things that, Gerard, make you and I very angry and why we teach a very specific class in our EMT classes, which we'll get to figure out which one. And it also touches base on the humanity aspect of what we talked about last episode. So kind of ties everything together without having just here's a discussion.
I like when things get tied together.
Yeah, especially on a bed. So, wow, nothing on that one?
I didn't even hear what you said.
I didn't either.
Okay.
I was actually looking at the glitter speck Gerard has on his
As soon as I
face.
said it.
I didn't understand the joke.
Wait, what'd you say?
I didn't even hear what it
Glitter
said.
right here.
I have glitter.
You do have glitter.
I've been like
You
staring
look like a
at
little
it.
elf. Little speckles on your
Feel
cheeks.
sparkles.
Yeah, as soon as I said that, I was like, oh shit, that did something.
And then they missed it.
I didn't hear it.
All right, good stuff.
Yeah.
Keep going.
Okay. So to get this started, we're at a very rural setting, right? Think Gilboa, but worse. Okay. Again, if you know where Gilboa is, you understand the reference. You have a volunteer fire response. 2 CFRs show up initially. You have a volunteer BLS ambulance with 2 EMT basics. You have 1 paid ALS ambulance with 1 EMT basic and 1 paramedic. And you also have the air medical helicopter, which is auto dispatched in this situation by 911, which carries 1 flight nurse and 1 paramedic. So to this call, you have a lot being dispatched. Okay.
I mean, for in the middle of nowhere, that's a huge response.
That is a huge response, right? Yes. And you'll see why in a second. So hospitals in the area, you have a local hospital 20 minutes away from the scene. It is a critical access only. So not a generalized go there, intubate, transfer out kind of thing. And then you have a pediatric trauma center by ground, 1 hour, or 25 minutes by air. Okay, so those are your two options for this call. So dispatch. Ground EMS is dispatched a Delta priority or priority 1 for a 2-vehicle MVA. One vehicle is told by dispatch that it was a rollover into a tree. Okay, so with that, do you feel like this response is good?
If all that's being dispatched at one time, yeah.
At all time, like one time, it's all, this is what we're dispatching gonna send.
2 ambulances, the helicopter, and the fire department.
Yep.
Send more and not need them rather than send 1 ambulance and need 3. So I'm all about it.
In fact, I said it's 2 cars. You're at the very least going to have 2 patients.
Mm-hmm. Okay. So a short while later, you have the fire response arrives first. They find 2 cars. We're going to say the first car is car A. Okay. That car is found in the middle of the roadway. There's heavy front end damage, no passenger compartment intrusion, front airbag deployment. You have 1 adult male patient sitting in the driver's seat who appears in significant pain. Okay. Your second car, car B, is found on its right side, off of the roadway, leaning against a tree. There's heavy left side damage and roof damage. Both front and side curtain airbags have deployed. There's 3 patients in that vehicle. 2 adult females, 1 pediatric female. Pediatric female is found unresponsive in the back seat. The female driver is out of the vehicle with a head hematoma, and the female passenger is entrapped within the vehicle. Now, we need to note that it's not because they physically can't get out of the vehicle, like they're wounded too much, they just can't get out. The car's on that side. The female passenger has a complaint of shortness of breath. Okay. Before we go on, where is your guys' initial? You guys show up as these CFRs. What's your first thing to do here? Where do you want to go from here before I tell you what they did?
Make sure these are the exact number of patients we have, and then get some more.
Okay. So what else do you want that's not already coming? So you have a BLS ambulance coming, you have an ALS ambulance coming, and you have an aircraft coming.
I'd say give me 1 more ambulance.
Okay.
1 more ambulance.
Okay.
Probably a wrecker. Something that is going to be able to, if the fire department can't extricate with what they have, something that we can use to stabilize that vehicle so they can really cut it apart without it toppling over.
Okay.
You know.
Anybody else?
Would not even think of a wrecker.
It's not something that I think
Good call,
about either.
nope.
Like that's the fire department.
Yeah, I don't know how you cut a car apart or how you do that. Just do it.
Yeah.
I don't know how that works.
Yeah, I'm just thinking if it's up on its side up against a tree and the passenger's on that downside, they're going to stabilize, probably try to go in through the top, but at some point it may not be feasible, so they might have to actually roll it back on its
side.
Wheels,
right,
on
right.
need a wrecker for that.
No, I understand your point. I just would have never thought of that.
Yeah.
We would have been on our side forever.
And with let's see, it doesn't say so heavy left-sided damage, so driver's side damage and roof damage. I mean, they could go through the front even if they want to cut out.
Yeah, roll the dash,
I don't even know about roll and dash. Just take out the front windshield
and then slide them out the front
and go out that way as well,
or the back, depending on where.
Right, or the back, depending on if they didn't have the ability to just roll back on or have, because how much cribbing are they going to have to be able to stabilize that? They might have to use the poles or something like that. But it's interesting to think about.
A fire department.
Yeah, you guys are talking over my head too.
I don't know any of that.
It's fire stuff. So patient care wise, you guys want extra ambulances, which I think is absolutely accurate here. MCI, non-MCI.
You have more patients than you do resources to take care of that patient.
Cool. So, this is these CFRs can declare an MCI. They chose not to. Whether that's a right or wrong decision, we'll see. Patient care, where do you guys want to go first? Do you want to just say, hey, let's tag people? Do you want to actually physically assess people? How do you want to look at 4 patients with 2 providers?
With 2 CFRs.
With 2 CFRs in 2 different vehicles.
You go
I
through
think you-
all
I think you-
patients
They have to
and
triage.
find the
I
life
think
threats.
you tag. I think you do a fast triage. Yeah.
Okay, so tag, awesome. These CFRs choose not to tag. They go right in and they say, "Hey, pediatric female, you're unresponsive."
They went to the red herring, yeah.
They went to the red herring, right? So they do an emergency extrication to the outside of the vehicle. CFRs look at this pediatric female. They find her apneic and pulseless. What do?
Start CPR.
Oh,
Start
see.
CPR, right?
I'm with them up until there.
They
Like
follow the red herring.
I would rapidly extricate them out to assess them,
Yep.
and then they're a black tag.
And then there, but you would black
Right.
tag,
Correct.
Right.
And that's
I mean, I don't disagree
Or-
with them
No,
going
that's-
there first.
That's not a bad idea. If it's easily accessible, just to remove them from.
Right.
Yeah, absolutely. Yeah.
That's the first one that I would check out too if she's unresponsive, or he or she, I don't know, boy or girl,
She.
whatever. I would get them out first, but the second that they're apneic and pulseless, you're in an MCI setting.
Or you could have a fireman who's not a CFR do just compression CPR while you continue on to the other patients and make sure there's no life
Is
threats.
fire on scene or?
so fire. I don't have exactly when they got there, but these two CFRs are there. That's the only ones at this time. So it kind of is, do you let one CFR get there, do that,
Impressions while I go and
the
rest. Yeah, sure.
until maybe another.
Do you?
I'm just.
I don't know if I
devil's
would.
advocate.
With 2 providers and 4 patients.
Like I said, devil's
3
advocate.
patients.
for
3
this.
patients, I was going to say.
If they're
So-
going to start CPR, don't both of you come out of the game. You know what I mean? It's.
I don't think you can pull either out of the game.
No, I'm not saying that's the right thing to do. I'm just saying what they did. They started CPR on the kid.
Both of them did? Sorry.
Correct.
I wasn't paying that
That's
much
what I'm
attention.
saying. Yeah. So
Thanks.
Don't take
Pull the
them.
Gerard.
Don't take them both out of the game.
Yeah,
If
no,
you're
I
gonna
mean,
do it, just
1.
yeah.
Now, going through all the other tags, right? So we as a table would black tag the pediatric unresponsive female that's pulseless and apneic. That's a given. What about the shortness of breath female that's still stuck in the car?
You have to make sure they don't have a tension pneumo.
Right.
So at least red up until this
Yeah,
point,
I
because we
mean-
don't know,
Right.
right? We have to assume. I'm going to green tag the
walking around.
because duh. And what about the gentleman in the other car with the pain? We don't know where the pain's coming from, but it appears that he's in a significant amount of pain.
He's conscious. He's talking.
He's conscious. He's talking.
Yellow.
Tag. I'm good with all those. So,
1 of
Full
each.
color
Look at us
spectrum.
go.
what was that?
1 of each.
One of each. Here you go. Right. So, they to get back to the call, the CFRs begin the CPR. They're doing compression only at this point. The volunteer ambulance is next on the scene. They arrive 5 minutes later. So we're doing CPR for about 5 minutes at that point. Okay. They go and they step out and they see, hey, we have an unresponsive female getting CPR. So what do? They load the pediatric code into their ambulance and they continue resuscitation efforts.
Now we've taken 4 providers on 1 patient.
Correct. And the other 3, the one is still sitting in the vehicle. Now, sidebar, this call gets very complicated with a lot of moving parts. So I'm going to try and do my best to keep you, there's going to be time jumps. I'm going to try and do my best to make it so you guys get a good, clear picture. So yes, at this point, you have 4 providers in 1 ambulance taking care of a code. You have the guy still sitting in his vehicle with pain, the other female still walking around with a head injury, and the other one still stuck in the car.
Is
Short of
he
breath.
able to get out, the guy who's in the car, because of the car, or he can't get out because of his pain?
Pain. Makes sense so far?
That's-
Awesome. So the resuscitation efforts continue. Manual compressions, they measure and they place an oral airway. So kudos to them.
Good for them.
Good
Hey,
for them.
airway.
Wow.
They begin rescue breathing with a pediatric BVM with an infant-sized mask. Again, maybe this patient was tiny, right? Nobody really has given me a size of this pediatric yet. So 6 minutes goes by, and the paid ALS ambulance arrives on scene. The medic, who I assume would do what in this situation?
Triage.
Start triage, right? Start looking
Re-triage, reassess.
Look at the bigger picture. No, they get in the volunteer ambulance too.
So there's 6 providers on one patient in
No,
another.
there's 5.
Oh.
There's 5 providers inside one ambulance
How do they
for
all
a
fit?
pediatric cardiac arrest.
First of all,
Clown car.
It's a clown car.
Lord,
And nobody's taking
and
care of
nobody
anybody
bothered to
else.
check on anyone else.
Nope. Not at this point in time.
So you could potentially have 2 other people dying.
Correct.
I
Focused
mean,
on
your
the one
shortness
dead
of breath
one.
could be not breathing at this
Right.
point.
Hell, your walking person could be dying
I know.
too. You
They
just
could
don't
have
know.
they
we
could have
haven't
a
really
head
done
bleed.
an
Who knows?
assessment on them.
Internal bleed, something, yeah.
I feel like Jess wants to say so. She's glaring
So
at
you
me.
said the medic went into the ambulance. What about the paid EMT?
So the paid
I thought
EMT
6.
stays outside and evaluates the other patients.
Good for
Go
him.
him.
Kudos.
Good for
him.
him,
Go
right?
PDMT.
I don't know if it's a him. We're just assuming
Whatever.
it was a him. But that paid
Probably a
EMT,
she. She sounds smart.
you're gonna need to check that soon.
Definitely, yeah.
I retract my previous statement. So by this time, the fire department was there, has been there, and has extricated the PD or the. By this time, the fire department's gotten there and has extricated the female passenger that was entrapped in the rollover.
Hey, go fire.
Okay, go fire. EMT walks over. They find her conscious, alert, and oriented ×4. No head, neck, or back pain. Airways patent. Breathing is shallow and painful. Complains of shortness of breath and pain to the right flank. They lift up the shirt. Bruising is noted to the right rib area with equal chest rise. No lung sounds are taken, no vitals are taken, and no treatment is provided. Are you guys okay with that?
I would have at least listened to long
I would
sounds.
have downgraded her to yellow, but
Okay.
definitely she needs a
She
ride
needs
into the
attention.
hospital, yeah.
Needs attention, right?
Yeah.
I don't know if I would downgrade her yet until if I'm suspicious of a pneumo, I would listen
That's what I was
to
saying.
lung
Would
sounds.
have
Even
at
if I
least
don't get
listened.
vitals, if I don't,
Right, we would do
whatever.
that.
I would prefer vitals, but
Yeah.
And again, this is kind of that triage section where we're still not doing vital signs. We're
Right.
still triaging
Right.
people based on what we see.
what you see
I'd still like to at least listen to lung
Yeah.
sound. Like that, I would take the 30 seconds to
to
do
listen. Yeah, see.
that to make sure they don't have attention. Now, granted, this EMT's not going to do much about attention. You
No,
know,
but
it's
maybe
not
they
like they can dart them.
I mean, but they can redelegate resources.
They can.
Like, hey, they don't have lung sounds on one side.
Right.
Somebody
you
needs to come over
need
here.
to be over here,
Right.
kind of thing. Okay. So the EMT then switches gears and moves on to the female driver. This is the one that was standing, walking around with a head
Who's our
injury.
green tag?
This was the green tag, correct. Finds her to be conscious, alert, and oriented ×4. Airways patent. Breathing's unlabored. No neck or back pain. Complaints of left-sided head pain. And he finds, or EMT finds, a hematoma the size of a silver dollar above the right or above the left eye. Again, no vitals, no treatments are given for this. Good with that?
Yeah, still green.
Still green,
I think
right?
so.
Moves on. Goes over, assesses the male driver of the other vehicle, who is at this point still seated in the vehicle. Conscious, alert, and oriented ×4. Airways patent. No head, neck, or back pain. Breathing's unlabored. Complaints of significant pain to the left hip and groin area. Does not take the time to expose. No vitals are taken. No treatments are given. Are we okay with this? The wheels are turning.
For triage, leave him as a yellow. As the resources come in, we'll and once he's out of the vehicle, we can, actually put somebody on him.
So do we have the resources already there, though?
Yes.
Yes.
See, I would
Yes.
redelegate. Somebody
We can
needs to go check
redelegate.
out the shortness of breath, and somebody needs to go check out him to do further assessments.
Okay.
A set of vital signs.
Yeah.
Pelvic fractures. You can have a significant amount of bleeding, so that patient could
Decompensate.
rapidly. So at the very least, stabilize the fracture.
I agree. Okay. But no, they decide to just meander back to the volunteer ambulance that has the code in it because that's what,
Without
that's
wait,
what
so
good
they just
providers
assessed.
do,
Hold
right?
on, they just assessed all 3 of them and just walked away.
Walked away.
It's definitely a guy. I take this back. It's so much
So-
more hope for this EMT.
I'm pretty sure that we are all not okay with that decision because again, now we're back to this is six providers
In one ambulance.
on
One patient.
on one patient. Now, I don't have information from this call saying that the paid EMT actually went into the ambulance and joined the code resuscitation.
But he might as well have because he's not doing shit for anybody else.
I can only assume that this provider just meandered around the ambulance and didn't really do much else.
That he comes on scene and recognizes that everybody needs to be retriaged. Like, I love the whole reassessment thing, but then go back and actually assess these people.
Use the information you
I
get.
have
Yeah,
a
like let's do
question.
some stuff.
Don't cover MCIs in class, really. So, first thing that you
Oh, she didn't take your class.
I was going to say,
Don't cover-
me and
You
Gerard There's a whole
like
day
you guys
lecture
are all
on it.
tagging these people, and I'm sitting here being a sponge, being like, "Take this information in, Kelsey." So, who would you, if you are one EMT and you aren't even bothering messing with trying to get those 5 people back, who would you do first?
Your red tag.
Yeah.
I thought we downgraded her to a yellow. Are we leaving her red?
So if you are one,
I understand the red, yellow, green part.
right? If you're one provider,
Yep.
right, you have to tag initially,
Yep.
and then go to your most severe. So at that point, you're red tag. As soon as you get one more person, now you can go reevaluate. If they change, then you can switch gears to somebody else.
But if
So
you
you're
had
saying
two
you had
yellows,
2 yellows. Which one do you go to first?
Yes.
Right.
The respiratory.
Yeah,
Yeah.
I agree.
So,
It's
but
just
you
agency.
also have 2 CFRs somewhere on scene. You could grab one of them, send
Yeah.
them to stabilize the pelvis.
But like
and
hypothetically, if
focus
it was
on the
you and your
respiratory.
partner and they're doing a code,
If there's somebody standing there, I'd be like, stand right there, talk to him, and tell me if anything changes. I don't even care if you're medical.
stand
You're
there and
just
talk to
a-
them.
Get a cop.
Yeah,
Find somebody.
there's so many on traffic accidents. So many. Grab
I
one
love
of them
that face.
and just have them talk to him. Anything changes, I'll be right back. But I would go for my respiratory too.
Yeah, and the only other thing I would say that if your red tag is not accessible until fire gets them out, then go down the line from there.
Yeah,
To your-
don't
to your
stand there
very-
and
yeah.
wait.
Because you're
Yeah,
yellow-
'cause now
yellow
you're doing
lights are
nothing.
yellow
Right,
red.
keep moving.
Okay. We don't cover that, so
I didn't hear that.
Yeah,
Ew.
let me know when you get them out. I'm gonna be over here doing something.
All right, so now we're going to switch gears. You saw what happened outside the ambulance. Now we're going to move to the medic has just entered. We're going to go back in time a little bit, and we're going to enter the code ambulance, we're going to say. Okay, so the medic goes in, finds the pediatric patient to still be pulseless with CPR in progress. BVM rescue breathing is estimated at around 20 breaths per minute, still using the pediatric BVM with the infant mask. The medic places the patient on the EKG and pads. Initial rhythm, asystole. They obtain IV access, 20 gauge to the left AC.
Oh, good for them. How old is this pediatric? Did we get an age?
9.
does the infant mask fit? Is my question.
We'll get there. We shall
I'm gonna go with
get
no.
there.
If they're
That's-
9, probably not.
So
Tiny 9-year-old.
I mean, if you're
Just pucker
only
the lips
hold on,
so you
no,
can
no, 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 no.
try.
If you're only trying to BVM the nose,
Yeah,
an
maybe.
infant mask might work.
Plug the nose and just
my question is, what condition is this child in? As far as
they're dead.
no, I get that. I'm talking about physical condition, bobblehead, things like that. Like
I mean, it doesn't
deformities,
matter.
things
They're
like- if I see that the kid has a snapped neck with a lot of step offs,
Obvious sign of
it's a
death.
pretty obvious.
it's a
you know.
traumatic arrest, unconscious, unresponsive, with no resources.
I get that. My point is what does the kid look like? Something to clue them into, hey, maybe you should stop doing this, that it's a lost cause, and go back and start doing something else.
All they
thing
see
is-
is a child.
And I've seen it before on a ton of scenes. It is really hard for an adult, especially if you have kids, to say that this child is a lost cause.
You're just heartless.
No, it's really I can say it.
Exactly.
I don't have kids. It's really hard for providers to go on and be like, this is the one that we're not working. It sucks that they're 9. It's a hard decision to make.
It is a hard decision, and I totally understand, looking at it from that perspective. But also, Gerard, you have a very good point. who has done a physical exam on this patient to find any of this stuff, right? According to what I have in front of me, nobody has done that yet. They just apneic pulseless. Let's fix the resuscitate, or the pulselessness. So I would hope that eventually somebody looks at that. Foreshadowing. So initial rhythm, asystole. Obtains IV access, 20 gauge left AC. Starts fluids, wide open. In there? Okay, cool. I was waiting for...
How much wide open?
Wide open.
Like, how much fluid did they put up?
We are assuming that since there's no mention of 1,000 bag within the chart, we can only assume that it was a 250, 500 bag or less. But we don't know. We don't know exactly how much fluid was actually given wide open. So that was one of the talking points, and we'll get back to it because there's a couple things here that we need to actually pay attention to just for guideline purposes, especially in PALS. So starts fluids wide open. Gives the first epi, 1 to 10,000 epi, 1 full milligram.
Not weight based.
Not weight based. So for the next 15 minutes, CPR is continued. 2 further 1 milligram, 1 to 10,000 epis are given. And this paramedic decides that they need to intubate the patient, and multiple intubation attempts are taken. All such fail. So there's no airway at this point. The OPA is never replaced once it's taken out.
Oh, Jesus.
I can't imagine they were having adequate ventilations with an infant mask, however.
Especially because they're just BVMing the nose. I mean, I have to assume that's what I see in my head is they're just BVMing the nose.
There's different sizes infant masks. Maybe it was the biggest one.
Little kid.
Yeah.
Maybe this 9-year-old was super small.
Like me when I was 9.
I don't know. We are going to assume that the ventilation continues with the ped BVM and the infant mask. No SpO2 is measured, and there's an ET-CO2, so an end tidal of 4 throughout this entire 15-minute process. Gerard is shaking his head in utter blasphemy.
Yeah, I don't know why they're still doing this with other people outside.
Mm-hmm.
So.
Okay. We carry on. Air medical arrives on scene.
Thank God.
So now we have...
Maybe.
That's what I'm saying.
Now we have the flight crew, right?
I hear the helicopter and I'm like, thank Jesus.
So the air medical arrives on scene, and the flight medic and the flight nurse both get out, and the paid EMT, who's been outside of the code ambulance...
What are they doing right now?
Standing outside of the code ambulance. Paid EMT walks up to the flight crew and gives a report of you have 1 patient with a hip fracture over yonder, 1 with shortness of breath over there, and 1 with a head injury over there, and 1 in cardiac arrest over there. So this crew decides, okay, this seems like a clusterfuck. We're going to call for a second aircraft right now because nobody at this point in time up until then has declared this an MCI. No one has asked for additional resources, nothing. So we still have exactly what this was dispatched with until the flight crew gets there and says, we should probably get some more things here. So we'll just ask for another aircraft. Why not? Okay with that? Yeah, cool. Anything to add?
Was the aircraft put on standby, or did they actually call him to respond to the scene?
I don't know. I'm assuming, I would assume that they just called them to the scene because who knows if the county would put 2 aircraft on standby if one's going, but I don't know how that works. That would be a you thing. So,
well, you can put the aircraft on standby so that they are heading towards you and, standing by in the air in the area if you need it. And then they're you don't have to. They're not actually going to land on scene until you say, "Hey, no, we really do need you." And at that point, that would make sense to have them be on standby, ready and available in the area. But until you've actually assessed the patients, you don't know if you actually need them yet.
I like that.
I remember that. My next MCI. You just mentioned 3 helicopters, but 2 on standby. That's a good idea, though.
Why not?
No, like that's actually a really good idea.
You guys did it the one day, or at least you tried.
I think I got 3.
Yeah.
2 of yours and 1 from the other place. The one from the other place was en route, and when I guess they realized they weren't needed.
Yeah.
Yep.
Give me them all.
I mean, that's a great idea. Like, send everybody, and then I'll back you
They
up
asked
as
how many I
needed.
needed, and I said,
All of them.
All of
as
it.
many as you can get me.
So any flight time over 8 minutes. So any call that's over 15 miles away, which is about an 8-minute flight time, we would lift and head towards the call. We typically stage at like town center, not directly over the scene, because we don't want to cause additional stress by flying right over everybody's heads.
We're watching you.
I don't know. There was one that they were like circling my ambulance.
Yeah, but
I'm
then you're like, oh fuck, I forgot to cancel the helicopter.
Go
And that
over
was
the
it, like-
scene just to be nosy and what's going on down there. But we'll just do like a circle and then stage in at town center.
Yeah, this is our
until we're
MASH
called to
flyby.
land.
So what'd you say? Well, there was an EMT standing outside with his thumb in his ass.
So these guys decide they are going to now start doing triage for themselves on the patients that have been neglected at this scene. So the flight paramedic moves towards the shortness. The flight paramedic moves towards the shortness of breath.
Probably a good idea.
Begins evaluation. They do a visual evaluation and find a possible fractured rib on the right side. The patient still complains of pain, but equal chest rise and adequate respirations. Okay. The flight nurse moves over to the man with hip pain. At that point, he is then just being extricated out of the vehicle by firemen and being placed on the stretcher of the paid ambulance. That's important because
that paramedic is in doing a cardiac arrest.
Because the paramedic's in doing a cardiac arrest. And where was the EMT for this entire time?
Standing outside the ambulance.
Standing outside the volunteer ambulance with the thumb in his ass, right? Flight nurse does the visual evaluation, believes he has a fractured pelvis. This patient is conscious alert oriented ×4 with good color. Flight nurse places him in a pelvic binder and escorts with the paid EMT that's been doing nothing to the paid EMT's ambulance. And now things begin to change. So as the flight paramedic is doing this evaluation on the shortness of breath, the back doors of the volunteer ambulance hurl open. Head pops out. I'm painting you a gorgeous picture. And just picture this. Doors fly open. Light blasts out. Fireworks exploding in the background.
Right.
Head pops out. Screams, "Get the fuck in here. We don't have an airway. We need you."
Wait, time out. Jess, this is a question for you. When you show up to a scene, if all of the providers are in the ambulance, who typically would give you a report? Or do you just show up and you're like, fuck it, I'm just going to go?
Triage really isn't supposed to be part of our...
It should be done by the time
exactly.
you get there.
We are there for a quick ride. We're supposed to get there. Somebody's
Pick 'em
handing
up,
us
right.
handing us the patient that they've decided is the most critical,
Right.
and we go as quick as possible. So, because we may have to make multiple trips in an MCI kind of scenario. Triage is not what we're supposed to be doing there.
So listening to this
but-
call,
If you showed up to a call like this and the
who do you look
triage
for
wasn't
report, I guess?
and the triage wasn't done, what would you do?
I would look for incident command. Incident command should direct us to the most critical patient, and we would fly that patient out. We're there for speed, and we're also in an MCI scenario. We could come back multiple times, but we can also take patients to different hospitals so that we can spread the patients out and not overwhelm one specific hospital. But incident command should really be, triage should already be done. It's not in our
Job
Guidelines?
description.
yeah. I guess it's on our job description. Really.
Well,
our
it
purpose
should
is
be
not
done
there to
already.
triage. Our purpose is to
Rapid intervention.
rapid,
and
yes,
go.
rapid transport.
I mean, triage should be the first thing that's done on these scenes, so you wouldn't be the ones doing it.
Yeah.
Because hopefully you're not the first ones on the scene.
But it's really cool when you are. She tells me that all the time.
I mean, do you often have to take a patient off an MCI and then go back and take another?
MCIs don't happen all that frequently,
That's true.
but it has happened where we've gone back to pick up a second patient from an MCI.
Can you just picture there's 3 people in a car accident? The helicopter has to take 2.
Mm.
You're like, I'm just going to
Mhm.
sit here until the helicopter comes back, and then I'll go.
Yeah.
Hopefully,
Balboa
there's multiple
Yeah, right.
aircraft in the area, so you can have,
would just be a
a,
risk.
That's when you have the
staggered
fire
arrival
chief
of the
sitting there
aircraft.
like the old Vietnam radio guy going, all right, stack up every 500 feet and we're going to land. And
We're popping smoke.
all right, so getting back to this, as I said, the ambulance doors fly open. The paramedic who's been in there for God knows how long at this point is now yelling at the flight medic to come in and assist with an airway. Okay, apparently they still don't have an airway. So the flight medic gets into the ambulance. The first thing they do,
A respiratory patient.
He was.
He was.
Oh.
But he assessed that patient, assessed that there were no life threats.
right,
And then
And
got
then
pulled
got
away.
got
and then
pulled
got
away.
pulled into the clusterfuck.
The code ambulance.
Black hole.
And at this,
Right,
maybe
the
he
black hole
doesn't
of
know
It literally is the
that
black
it's
hole.
the patient is still
It's sucking
coding.
everybody
Right.
in.
Yeah, he
gotten
probably
pulses
they
back.
probably didn't go.
I mean, if I'm on scene and I get a crew from a helicopter, I'm going to watch them and be like, what am I doing wrong and why are they doing this? So if they don't immediately run into this ambulance, shouldn't that clue you off like, well, if the flight crew's not that worried about it, why are we?
Yeah, but we also have
The
to
dead
we
kid,
also
so-
have to sit there and go, these guys have been at it for at least 20 25 minutes at this point in time in the ambulance. So I mean their thought process is do this, not anything outside of the doors of that ambulance. They don't know what the fuck's going on.
I mean, you can hear a helicopter coming.
Yes.
They're not that quiet. So if they don't walk in the next 3 seconds, they'd be like, what's not adding up?
I mean, the situational awareness is that their whole world is now inside this ambulance. They're not hearing anything. They're not seeing anything except what's in front of them. And they're probably in scramble mode still.
I mean,
And
that's
I
just
think
dangerous.
Gerard really hit the nail when he said it's the black hole. Everything just gets
It's
sucked
just getting
into that black
one
hole.
person after the next is getting
Oh, I get
sucked
it.
in there.
Mhm.
Yeah.
So the flight paramedic gets the story from the ground paramedic and does the best thing ever. They do an initial exam, right? Here's the initial exam. So they find ecchymosis to the front of the forehead, stable pelvis. However, there's bruising noted on the iliac crest. Their belief is from like a seatbelt type injury or something like that. Skin is pale, cool, cyanotic. Pupils are dilated, non-reactive. That's what they find initially. Was that a hand going up? Okay. The flight paramedic now wants to have a conversation with his partner. They ask for the flight nurse to come over to the ambulance to have that conversation. Flight medic reports to his partner that an airway is needed. The ventilations are being performed by this pediatric BVM with this infant mask, but they are not effective at all. There's no chest rise seen. There's no nothing that they can see. They also report that while they were at the head doing an inspection, they find significant crepitus to the back of the neck. And they decided, we're going to place a C-collar on this patient. And then, as bad as it sounds, I think the flight nurse said something that I would probably personally say, is the flight nurse asked if they really want to go down this road. And it sounds terrible, but I really
good
think
question.
it's a brilliant question in that, because now Black Hole of Doom, they're about to get sucked into this shit show as well.
It's a question.
Now you have what, 7 people in this ambulance?
It sounds like though the medic just wants to put in an airway, and then
see.
and
Right.
you know, just so that they have an adequate air with, you know, and then hopefully move on.
Right. And I want you to kind of comment this, because that's exactly what this paramedic or this flight paramedic and this flight nurse have the conversation about. The flight paramedic believes if I just drop a tube in this pediatric code, we can say, hands off, go transport one of the other patients. And that they're kind of feeling cornered into having to do this for the ground crew. I want your kind of thought process, because I have a thought process on the ground crew. We always talk all the time about, you know, when ground crews are swimming in waters well above their head, they look to the air medical crew to save them. I kind of feel where that is. Like, I feel like that's where this paramedic's sitting at right now. What do you think?
So this medic has called for help. I cannot imagine this medic ever calling for air medical again if that crew didn't go and help.
Mm-hmm.
And that, you know, we only get called by, you know, providers. We don't get dispatched by, you know, bystanders. We get dispatched by providers. So we have to maintain that good rapport with EMS providers. And I think at the very least for this crew, they could place an airway and make this, you know, and then allow the ground medic to continue care now that they have an airway, and you know that intervention that they were struggling with is taken care of. They should be able to continue. ACLS is the same for us as it is for ground,
right?
And then handover care. But if I think it would have been a very bad idea for the flight crew to not do anything.
Mm-hmm.
To just say
That's a good point, though, that you guys have a whole nother, like, just being on a flight crew is like, oh, well, you're dealing with these idiot ground providers, but like you have to play nice in the sandbox because that's who's calling you.
Mm-hmm.
Yeah.
That's a good point.
There's a whole other aspect.
Yeah.
And that when I got this call to review, I thought that was a very interesting dynamic that we don't really have to think about. Like, if Gerard and I were the second medic on that crew, we would have walked up and been like, no, just stop.
Well, how many times do you walk up to, like, even, or not you guys, but how many times does paid providers walk up and there's volunteer service and who knows what the fuck they're doing? And they'll just be like, get the fuck off my scene, or, you know, whatever. Could you imagine if we had to play nice, as like paid providers had to play nice with the volunteers?
You tell me I have to all the time.
You do. It would be a totally different world, though.
Yeah, I mean, in my experience in that realm, I mean, that's pretty much what I would do is, you know, even if I see them doing something completely, you know, bass backwards, I would, you know, thank them for what they did. Thank you for the report. Okay, I'll take it from here. Here's what we want to do. Let's get this. And I try to figure out a way to unfuck the whole situation.
Right, fix it, but you have to be nice to them.
Right.
And like, oh, you didn't do
in
anything
a tactful
wrong,
way,
but...
not get the fuck out of your ambulance, you know?
Right. But even like working on a BLS service, where I work, we get that from the ALS providers. Like, oh, you're just a stupid EMT. Like, okay, fix my problem. I don't know what to tell you.
And I say, you know, you reap what you sow. If an ALS provider is going to be like that, then they should expect nothing from their
You've earned the
BLS
disrespect.
crew at all.
But it's just interesting if you had to go into every call thinking the way that the flight crews do, like, oh no, we need these providers because we need them to call. Right. That's interesting.
Yeah. Mm-hmm. And it's like I tell people all the time, you know, in classes and stuff, I say, you know, when you're out there and, you know, you're responding, you know, either as a BLS volunteer or whatever, and you know, everyone likes to use, the jolly volleys, right? Well, I want them to come out next time. So I always tell them, be polite, be courteous, listen to what they have to say. If they're complete morons, whatever, just thank you, appreciate it. Thanks for coming out, and I'll see you next time. So I guess my question would be, looking back at it now, I know I always look back on things and, you know, I wouldn't say second guess, but kind of go over them. Would it be better to, put the tube in and just say, okay, you know, via con Dios, or maybe just explain to the crew,
either.
Go with God on your way.
Is that Spanish?
It is.
Yes.
Hernandez.
That is my favorite thing ever. So your dad never taught you Spanish.
And Quill.
So, would it be better to go ahead and, you know, do what they want, put the tube in, like you said, you know, just kind of keep the process going, or would it be better to, I mean, these are all, you know, providers that have gone through the training, especially the paramedic. He has gone through paramedic training. He understands, or she, whatever, you know, somewhere in that brain is the information about this not being the right thing to do. Maybe that realization needed to be made, maybe in a very tactful way, like.
So maybe you go in and you put the tube in while you're having this discussion of
right.
like,
something.
This is going to be the last effort. You know, there's too many patients. Right.
Just to kind of snap their heads back.
Right.
Out,
Just to put them back in the situation.
Right.
Like, this is not the only patient from this car accident.
Right.
This 9-year-old was not driving both cars. So we have other patients. We need to do something else.
Right, exactly. No, exactly.
I'm just saying, like,
they've all gotten pigeonholed. They all went into the black hole.
Right.
Maybe while you're doing that, let's get back in the game. You know.
I didn't hear that.
I have a question. When you fly, does it have to be both the medic and the nurse to intubate, or could like your medic do it with like ground medic?
In an MCI, we can split up.
Okay.
We don't have to stay together, but
Like
typically when we go onto a scene, one person carries the monitor, one person carries the bag.
Yeah.
And then so when we split up, you may have to come together at some point in order for the right person to have the right equipment to do what needs to be done. And I'm sure in this kind of situation, they may have had to come together just to do a quick discussion.
And even just transfer gear.
Yeah,
who knows what each
I was just
carrying.
thinking if that was what they wanted to do and get an airway and be like, okay, this is like try and pull them out, but you could have one person do the airway and the other person start loading up whatever patient they're going to take.
I mean, but at the end of the day, you're taking another provider and putting them on a situation that doesn't need, what are we at, 6 providers
7
now?
in the ambulance.
No,
I mean,
now they're
2 CFRs, 2 EMTs.
and a medic.
Medic,
two
and
I
the
can't
flight
imagine they
crew.
all stayed
so.
in the ambulance though when they called the flight
Not even
medic
room to
and
breathe
maybe
then.
the CFR stepped out and it's just the medic, the 2 EMTs, and the flight medic.
Yeah, but even then you could be like, okay, 1 EMT, go do something.
Mm-hmm. Yeah, really, how many people do you need? It's that how
Well,
many
again,
people
it's
do you
not
need to do one job kind of thing?
But even at this point, it's not the flight crew's job to delegate tasks to people. They're not there for that. They're
not there for that, but no one has
Are they
established
allowed to do
command
that?
at this
Well,
point.
and that's the big problem is the individual that should be doing that is
Doing other
pigeonholed.
stuff. Yeah.
Is tunnel visioned on one thing.
Yep.
Are you allowed to do that? Like, take over?
Well, so seeing as how incident command in this situation has not clearly been delegated and triage not completed, then yes, if somebody needs to organize. So I would say, yeah, the flight crew should probably organize, figure out who they're taking, and then go in as quick a fashion as possible.
So moving on. So just
I would love to be on the scene that you have to tell somebody to stop doing something.
Again, we have to be nice. So,
But still.
try and do
could
things.
you imagine my wife, the nicest human being on the planet, be like, stop it.
Yeah,
Get
exactly.
out of your ambulance.
Well, everybody has their thing too that overwhelms them, and this was obviously a case where that the kid pulled on all these providers' heartstrings,
Absolutely.
and they they got sucked in and they couldn't see the big picture. And on the other hand, too, you have the two other patients who are conscious, alert, and oriented. Granted, they have significant injuries, but they're not red tags right now. So maybe they felt they had time to work this code.
Mm-hmm. And again, I guess really all roads lead back to not doing a proper scene size up when they got on scene, recognizing, hey, we're going to need more people. They could have had another, ALS rig coming with another paramedic who might have, got on scene and said, hey, this shit ain't right. We need to do something about this.
Would have walked right into that ambulance.
Slugged into the black hole.
How many paramedics can we fit in one ambulance?
So how quickly did this go? Like how long from the time of the flight crew arrival to the time that they made patient contact with the, what's the time frame? How long did they spend with the two patients? And then how long did they spend discussing the intubation before they actually did it?
5 minutes.
From what? From the time?
From aircraft landing, report given by EMT to conversation between flight nurse and flight paramedic.
Okay, and then how long from the time that the medic made patient contact with the pediatric patient to the time of intubation? Because
you don't want to know.
I think we do.
2 minutes.
Okay, because another thing that why didn't the medic change out the mask, make sure that adequate BLS interventions were being administered before, and maybe go that route, send them off with adequate BLS ventilations versus the tube.
Because I think, I go to Gerard's point of there's so much overwhelming stuff happening. Look at all of the minute things that are going wrong, right? Wrong dosing in fluid resuscitation, wrong dosing in epinephrine, not seeing the fact that there's no SpO2, there's an N title of 4, there's no chest rise. They didn't do an initial assessment. They're missing all of the big picture things because they're doing monkey skills at this point. Do an IV, push an epi. Wait 5 minutes, push another epi. Do some CPR, push another epi.
Do we know anything about the experience level of the paramedic?
I do not. I do not. So at this point in time, since we're still talking about time, CPR has been done on this pediatric patient from the start of CFR CPR to the point we are now, 30 to 40 minutes. It's a long time, right?
And now they've got a tube.
So yes, the fourth epi is pushed by the ground paramedic at this point in time. Again, 1 milligram, 1 to 10,000 epi. And at the same point in time, the flight paramedic undoes the C collar, video laryngoscope, puts in a 6 tube, 18 at the lips, confirm, easy, waveform, awesome, lung sounds, cool. The discussion that the nurse and the flight paramedic had was that drop a tube, give it back to them, let's go transport one of the other patients on the scene.
Right.
Maybe that hip fracture, maybe that shortness, whichever one, right? So the flight nurse wanted some backing, calls their medical director, because you guys have different medical directors than like ground EMS. The flight nurse calls medical control and simply asks permission for turnover of care back to the lower level provider, because technically it's turning it down, not up in their case. And just like what happened to you and me, Gerard, during the phone call, rhythm change, asystole to PEA, or pulseless electrical activity. And then pulses come back. So ROSC is obtained. And a set of vital signs comes back with heart rate sinus tach at 134, a end-tidal CO2 at 34, and a SpO2 of 94%. And this is the choice of the flight team at that point in time to just steal this patient, load him onto the aircraft, puff it to the 25 minutes to the pediatric trauma center. So the flight crew switches them to the vent, 22 breaths a minute, moves to the aircraft after that's done. Initial BP is 84/50. An IO is started. Fluid continued via the bolus method instead of just we're going to let it drip. BG's taken, BG of 333. A warm lactated ringers is started. And
What?
Lactated ringers, it's...
Isotonic solution.
Yeah. But better.
Okay.
Due to the hypotension and the BP dropping to 55/30, the flight team starts a levofed drip at 5 mics per minute, and that raises it to around the mid 60s over 30, like 39, 38, 40 ish. So sinus tach is maintained in the 130s, end titles maintained in the mid 30s, and SpO2 maintains above 94%. Kid makes it to the pediatric trauma center. Awesome. Surgeons take him and decide that CPR has been done for way too long. This child's sadly gotten a anoxic brain injury, but good things that come out of it.
Organs.
Oh, yeah. And you can just say things. You don't have to point to it. Like
Internal decapitation is what he had.
That's what I was thinking in the very beginning.
And ultimately, the good thing that comes out of it is this child does become an organ donor. But,
Excellent.
So out of all of this, there's one silver lining, right? The pelvic fracture back at the scene is actually airlifted by the second aircraft that came to the scene, thanks to the flight team.
Really?
And the two females, the passenger that had the shortness of breath and the driver who ultimately had that minor head injury, were just transported by the ground people that were there in the first place. So both to the trauma center that the pediatric went to. So there's a lot to digest. We've digested most of this call. Is there anything that you guys that's screaming out that we didn't really touch base on? I know we didn't touch base on like the meds and why we don't give 1 milligram of epi to a pediatric that.
I mean, that would give
is a
a rock a
9-year-old.
pulse, so it doesn't surprise me that they got pulses back, but
So
it didn't do anything for the child.
my thoughts too. Pediatric cardiac arrest is related to hypoxia unless proven otherwise.
Yes.
And this was obviously a case of hypoxia because as soon as they got the ET tube in
They came
and
back.
provided adequate ventilations, he got pulses back.
Yep. And we've talked about that before. We've given studies on how, significant. And look at, again, we go back to the first rhythm is asystole that they find them. And we've also discussed the fact that when you're hypoxic, severe hypoxia, you code, where do you go from there? Asystole. So, even there's another, tie-in that we've had those discussions before. So,
Granted, this kid had an internal decapitation, so that also was, but,
Right.
that could have caused asphyxiation.
Right. It's a traumatic anoxic
Yeah.
combo.
Yeah. And again, even if the CFRs or the initial EMTs did an assessment, instead of just jumping right in and being like, I'll take over compressions, move them over here, maybe they would have found that before the 30-minute mark, to sit there and go, well, maybe this is not life-sustaining, right? It goes back to that whole black tag kind of thing. But again,
I mean, it makes me wonder if there was another more critical patient on scene. Like, I would hope that they would recognize that they need to focus on the adult that still has a chance versus the pediatric that's
I
still
don't
black tag.
think they would.
I think these guys were just.
I think they got lucky that they were yellow tags and that potentially
And they didn't decline.
probably had good outcomes versus having a critical patient that actually made a difference, that they did not provide care, that they focused on the black tag.
I agree. But, I when I heard about this call, I really wanted to review it solely because of the black holeness factor of the This is why New York State does that same question every year on their test. You know, which one do you treat first? And it's always the pediatric,
but it's
6-year-old in cardiac arrest
It's
or whatever.
hard. And
It's
I
really
think it's
hard.
an easier decision to make if it was an adult that
Absolutely.
was apneic and pulsus. So I get it. When you have a kid, nobody wants to say, like, we're not working this kid because it's not worth it. Like, I get it. But at the same time, you have to focus where you're needed.
Right. And if this was, again, if all you do is change a couple factors, make this 2 patients, you know, and you have 2 ambulances and a helicopter coming, okay, cool. You guys
But
go
even
over there
at-
and do some stuff.
I mean, even if you change it and don't make it an MCI, at 40 minutes, you haven't been bagging them properly.
but they don't know that. They didn't realize that, or they would have fixed it,
Yikes.
you know? And that's, again, something that we talk a lot about proper ventilatory management. I've said it 100 million times. We all suck at bagging patients. We all think we're brilliant at it. This just shows that we all suck at bagging. You know?
The other thing that I guess if you want to call it they went down the CPR route and everything, so they're doing it anyway. So you have trauma and an arrest. Did they ever dart the kid?
Nope.
So that would be one other thing that comes to my mind is that wasn't done.
Mm-hmm.
Yeah. Bilateral decompressions
and
is
make sure.
warranted in a
I'm
cardiac
curious.
traumatic arrest.
I'm also curious just what type of CPR they were doing. I know it was manual, but was it 30 and 2? Was it 15 and 2? I never get a accurate description on whether it was, there's a pediatric patient. CPR, pediatric, 2 rescuers, it's 15 and 2. Even on, an 8, 9-year-old. I'm wondering if they were doing the 30 and 2 or the 15 and 2. We don't know. But it's something else that, is a good reminder for us in the field listening to this,
To me, it almost sounds like, I know it's easy to say, oh my God, they're stupid, they're idiots. And then there's, you think about it. And to me, when you look at the whole thing, it almost seems like there was just that initial, flicker of panic.
Mm-hmm.
And then the next crew that showed up, it spread to them, and it
just
just
the
followed
pucker.
suit. It's the pucker, right?
Yep. And
At the
like
same
you
time,
said, it's that
too,
black hole.
isn't it in the protocol, you cannot terminate on a pediatric patient, terminate resuscitation efforts on a pediatric patient in the field without either consulting medical control or
Probably.
transporting?
I believe it is.
Really?
I believe it's
Even for
medical-
trauma?
I believe it's medical control, isn't it?
I
So
don't know.
granted,
I'm
an
not sure.
MCI changes things and provider judgment, should come into effect here. But if the providers are thinking that in the back of their minds that, hey, we can't terminate this, then that would also be a factor in
First
why
one
they
is age 18 or older.
But if they didn't start,
It would have been a non-issue. Yeah.
So it says on pediatric, consider calling medical control for termination of resuscitation or initiate of transport after 20 minutes of CPR. So, and that's at least in our local. I mean, who knows?
20
Listening in
minutes,
a
is that what you
different
said?
20 minutes. Listening in a different state, it might be completely different. But at least here, the protocols we work under says 20 minutes. So they could have called after 20 minutes and said, hey, this is what happened, blah, blah, blah.
But at the same time, they didn't have a definitive airway even after
No.
20 minutes. So they didn't have a key intervention that I'm sure if they called medical control would have said, you need
Get
to
an airway.
get an
Right.
airway.
At least
Right.
get an airway. Yep. So thinking again on stuff maybe they didn't have, we don't know, is rescue airway, right? The information that I got from this call is that there were multiple intubation attempts. I can only assume multiple as I can take 2 and then pass it to Gerard and he can take 2 and then rescue airway.
But that was the only paramedic on scene until air
So,
medical arrived.
If I'm me in that situation, 2 rescue airway.
Exactly.
Where was the whole rescue airway? Now, we had discussed off mic, our agency doesn't carry a rescue
Small
airway
enough.
that tiny.
Right.
So maybe they were in the same boat.
You just didn't have the option.
I don't know.
Yeah.
They might have just not have had the option. But why don't we carry rescue airways for pediatrics? At least in our area.
Good question.
But the
good
real
question.
answer? Costs money.
Yeah.
Everything
Like
costs money.
everything-
I know,
think
but it
I've-
costs money, and we don't do enough to warrant it. Like,
Yeah.
as terrible as that sounds, that's exactly why we don't have
Yeah,
them.
it's true. I've learned anytime you ask, why don't we in EMS?
It's
usually
always
comes
money
down to
related.
Yeah.
They don't want to pay
Well,
for it.
and then there's another good thought, for down the road, especially for, those of us that practice in this state and other states that have similar protocol. You have a pediatric arrest or any kind of pediatric thing where you might need to intubate, it might not be a bad idea to call them and get them flying towards you.
Yeah.
Well, I think that's true for any respiratory, really. Like, any airway issue, you should have the helicopter in the back of your mind.
Especially for those that don't have RSI
Yeah,
or don't,
for
there's
sure.
a pediatric patient that might crap out on you, maybe an asthmatic or whatever that we don't have, because again, we all suck at intubation because we don't ever do it. So here's the perfect example of we don't practice ped airways. This provider missed ped airways, we don't have a backup device. So what do?
No,
Our backup device is
The helicopter.
the helicopter.
and
Well, yeah.
And we are called for that,
Yeah.
for airway management frequently.
Yeah.
By ground, but also by some critical access
Well,
hospitals.
hospitals. I was going to say, I've seen it in the hospital, too.
Yeah.
yeah, no,
I mean, and just because you call them doesn't mean, like, you guys jump on the ambulances and will transport
Yeah,
in the
we
right
do.
situation,
Absolutely.
right? I mean,
one of the places I worked before, and actually two places I worked before, no RSI capability at all, and like they were my go-to for the air medical people were my go-to for basically anything with airway. Like as soon as there was an airway issue, it was, hey, is the crew at the airport? Okay, let's go there.
Yeah, and that's
not?
that's that great things outside the box kind of stuff that
I mean,
you got to think
you'll
about.
think
as a
of that
provider.
when you're far out on an ambulance, and you'll be like, "Oh, I'm going to go to the closest hospital so they can secure the airway, and then we'll, go to the appropriate spot from there." Why not call air medical, and then you can just go to the appropriate facility from the get go?
Yep.
Bring respiratory to you, and then
Great, and then run
absolutely.
fast.
But it is funny about the critical access because in the same agency, we had one of those little critical access hospital
Clinics.
I'm not trying to diminish what they do, but yeah, there were times they would call us down to intubate, because we were working out of the back of the hospital, or go over and get the air medical crew and bring them over so they can RSI this patient. It was I've seen it done. Yeah.
It's
Know your resources, I guess.
know your resources, and we're
Do a good scene size up.
right, and don't be afraid to utilize certain resources like air medical. I mean, there's plenty of people out there that are like, I won't call them, or refuse to get them put on the county standby policy, or
Threaten to fire you if you ever use them.
or oh yeah, you could just drive them because you're close to the hospital. Please, I'm
There's
not going to
no
take them to the
benefit.
local.
You could just get there's absolutely a benefit.
Yeah, there's always
You're
a
bringing
benefit.
higher
Higher
level
trained,
of care to your
exactly.
scene.
Higher
Yep.
trained.
So if that's your kind of boat, push back on the boat a little bit. If it's, we always say what's best for the patient, that's what we do. If the best thing for the patient is a quick ride with RSI capabilities, pelvic binders, meds that we don't even know what they do, yeah, I'm gonna go with them.
It's a whole bag of voodoo magic. But
You
no,
have voodoo magic?
They really do.
Totally.
It's true. Like for the agency that you work for, that you fly with, I know from speaking with you and other providers that work there, I have to assume it's the same for other places too. In the country, that you'd rather be called, scramble, get in the air, get halfway there, and then be called off than to not be called at all. And then at the very last second, hey, by the way, we got a shit show for you.
Yeah, definitely.
Here, save this.
Right here, save me.
I'd rather be put on standby, get going to the scene and get turned down, but also if I get put on standby early so that I am available, so that our resource is available to you immediately in a timely manner. It doesn't make any sense to use air medical if you're going to waste time waiting for an LZ, waiting, for us to arrive because you didn't call until after your assessment, after you decided, that the okay, I really do need help. If you have enough information on dispatch, the earliest that you can put us on standby, the better, so that the time saving is really maximized.
And don't be one of those providers that like the county or whoever your dispatch center is, puts air medical on standby on your dispatch. And then as you're driving, woo, 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 you're like, yeah, cancel the bird. And you've not even stepped out of your ambulance yet, because I've been there. And when I was an EMT, I had a paramedic that would do that all the time. And I would be like,
you're going to screw yourself.
You're
going to screw yourself one
idiot.
time.
So surprisingly, we didn't get along. So he used to pick up the radio, be like, yeah, you could cancel, helicopter, blah, blah, blah. And I'd be like, so I'd pull up my phone and be like, hey, county, you can put them back on standby. And then hang up as I'm driving.
That has happened a lot, actually, where we've been stood down and then, redispatched 15, 20 minutes later.
Yeah, and
by the time we get there, patient could have been gone into the hospital by the time that we get there.
Yeah.
I won't even do that. Like, our county will dispatch air medical based on dispatch information. So like the nursing home in our facility, and just about any person that falls will meet that criteria. Right. And I still won't cancel you until I get there, like just in case.
Yeah, usually it'll be
that one
there's
day.
a really great LD right there, though.
Yeah, usually it'll be, my partner, his radio crackling. What's your pleasure with the helicopter? Oh, yeah, that's right. Yeah, you can send them down now.
Yep.
Oh, hey, just wave as you cancel them because they're there.
But no,
We're starting to run out of fuel. We won't make it to the hospital if you don't turn us down.
Can you make a decision now?
But no, I think one of a really good example that people who listen to the podcast will see is our very first podcast was, that tractor trailer where, the paramedic called early, or didn't even call early. It was the automatic dispatch. Mm-hmm. And
I love that.
While they were still en route, they said, the air medical accepted the mission, and that paramedic said, yeah, launch him.
Mm-hmm.
Absolutely.
Yep.
And then it turned out to be a blessing, when he got there. So
yeah. If you didn't listen to it, go back and listen to it, because it was the air medical was able to be used on scene, and with that extrication and provide care that we couldn't. So I think that's a really good episode to listen to, especially with air medical in mind. Mm-hmm. Anything else for the table to add? I think this is one of our longer episodes, but I think this call is absolutely worth it. Anything? Yes.
We hit it.
Yeah, just the overall. Like I said, it's easy to beat people up afterwards. I've been on the receiving end of it, and unless you were actually there on the scene, again, like I don't know anything about this paramedic's level of experience. It could have been fresh out of the box. For all I know. I would hope they're not a seasoned paramedic.
And I would hope that, as we say, anytime that there's a difficult call on this show, that they learn from it. They look back and they go, maybe I could have done something a little differently. Yeah. Maybe if I didn't go into that truck in the first place, maybe something would have, come out a little differently.
No,
I've seen seasoned medics that I trust, that I, provide good care, make that same decision.
Yeah. Mm-hmm.
So I get it.
I've been on call where, you get there and everyone's yelling for you to come take care of this one person, and you go running over and that person's dead. Mm-hmm. No, you got it wrong.
Yep. But it takes somebody,
being a 9-year-old, and you get there and everyone's yelling, hey, we have a kid in cardiac arrest, and then that's all the information you get. Like I said, I'm not gonna.
It's tough to say no to that.
Yeah.
Without You know, like if that was me, you feel like a dick afterwards going, no,
But there's a lot
I'm
of,
just going to go that way.
There's a lot of human error to go around here, but
We live, we learn, right?
we practice medicine.
So we're going to end it there, guys. We will see you in February. Have a good rest of the January. I'm sure the snow will be flying soon. And next episode, we are going to be talking all about EMS education. So I think that's going to be a interesting debate.
Heated.
I don't think it'll be heated. Gerard won't pound the table too hard.
I'll just put my arm out.
Just get the pads ready.
We'll give him a pillow.
We'll have Boba Fett guard
Well,
the,
plus
the
we're gonna have a very special guest who I think is certified in literally everything under the sun, and he's a state fire instructor as well as a EMS instructor. So I think coming with that education experience, being on the learning end of it, will add a different dynamic to the conversation as well. So till next time, guys, stay safe out there.
Donuts.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.